Thank you, Shal. Good morning again. And after dreaming with Aldo as regards the next future, we have to come back on the practical ground. And speaking about a rationale for adjuvant and neoadjuvant therapy, I have to admit that unfortunately we are still in between the clouds. However, there are some real things that we have to consider as regards the possible place for adjuvant therapy. When the surgeon speaks about radical resection, probably they lie, because the truth is that some patients will recur and eventually some of them will die despite what we define as a radical surgery. And the other side of the surgical truth is that the intent of radicality, it is not radicality, unfortunately. And radicality is function of the aggressiveness of the disease, such as N and M codes, and it only partially depends on surgeon hands. On the other hand, it's also true that for all the sites, even if with different rates, and might be also related to the extent of both the resection and the lymphadenectomy according to the surgical skill. Because we know that we are dealing with a disease with different kind of extent, as well with a different kind of aggressiveness, as well as with different kind of size. And so far, we know very well, from oncological point of view, that there is an indirect relationship between oncological safety and the sparing tissue. So far, there is enough room for thinking adjuvant, and this is particularly true in the subset of patients who were operated on for a carcinoma despite neuroendocrine. But for cooking a good dish, we need both the right recipe and the right ingredients. And if we look at the setting of adjuvant therapy, it means that we need some background information for better selecting the possible candidates for adjuvant treatment. And what we need to know is the overall survival after resection, the disease-free survival as a median time and rate of recurrence, and factors associated with them. Unfortunately, when we look at the literature, we have almost all time the overall survival and the median time of survival, as well as the rate of recurrence in different time, but there are very few information as regard the disease-free survival, both as a time or recurrence rate. If I have to give you my personal point of view, if we have to try to score realistically the prognostic factor associated with disease-free survival, I would say that probably the worst is to have a grading 2 and 3, according to the WHO classification of 2010. The presence of liver mets are the second worst prognostic factor, as well as positive node or an R1 resection, which was demonstrated as an adverse factor only for disease-free survival when we are speaking about liver surgery for neuroendocrine mets. Moreover, we have also to establish which is the aim of our possible adjuvant treatment, and probably among the different targets, such as the number of patient cured, overall survival, the most important factor which might have as a target is the disease-free survival, since despite recurrence, these patients usually live long. But unfortunately, we miss another information at which time we establish the edge for saying whether or not an adjuvant treatment works. To make the story even longer, we have to use different drugs in order to achieve our goal. And as you know very well, we are speaking about somatostatin inhibitors, radiometabolic therapy, selective internal radiotherapy, which is still experimental and belongs only to few countries, tyrosine kinase inhibitors, mTOR inhibitors, and chemotherapy. But again, if we look to this long list, we have to consider from surgical and adjuvant treatment point of view that some of them are cytostatic, such as somatostatin inhibitors, and some of them are cytotoxic, being the majority in between. So far, if I want to control the disease, probably a cytostatic drug is enough, but if I want to try to cancel a possible minimal residual disease, I need a cytotoxic drug. But, last not least, we don't really know how long should we treat the patient after radical surgery, or the so-called radical surgery. How to find the right way? I imagine when I prepare this speech that there is a first step that we may recognize quite easily. And the first rational scholastic division looks like at the G3 and poorly differentiated tumor as the first target for adjuvant treatment because they have the highest both recurrence and mortality rate. Chemotherapy is the only option, and so far probably they are a good field for a multicenter radical randomized clinical trial comparing chemo versus observation. But I have also to admit that it's a very small field because they represent the minority of cases that we are going to operate it on, and they are also rarely resectable because of their aggressive behavior and their advanced stage at the time of diagnosis. There is a second possible clinical field, which is liver transplantation for patients with neuroendocrine liver mets. You know that the figures in the literature are quite nice as regards the 5-year survival. Despite this, if we look at the 5-year recurrence rate, you may see that there is a recurrence rate quite high, between 23 and 90% of cases. It means that we can expect a recurrence in almost half the patients that have been transplanted. But why is the second possible field? Because we already use some drugs as acting as immunosuppression, for example, tacrolimus. And in this setting, probably it is not wrong to imagine a multicenter randomized clinical trial using as an experimental drug everolimus, probably at the half of the dosage that we are using in the clinical practice versus traditional immunosuppression in order to try to see how long we were able to increase, if possible, the disease-free survival. But again, we do not know at which time we should establish the cutoff, as well as we do not know how everolimus works as regard toxicity in a long period of time. There is a third realistic clinical field, which is again, between parentheses, curative surgery after for liver metastases. And the background is that, again, despite a very good long-term survival, after resection of liver mets for neuroendocrine tumor, the recurrence rate is quite high. It was almost 80% of patients at 5 years, with a median time to recurrence of 20 months. And the reason is quite easy to understand, because whenever a surgeon speaks about a curative surgery, we have to consider that despite the beautiful imaging that Anders has shown yesterday, we are able to recognize less than 1/5 of the lesion presence whenever we study the pathological specimen with the 3 or 4 centimeters lines. It means that usually we recognize almost 5 liver mets. Intraoperatively, this number increased just a little, becoming more accurate. Despite this, when we look at the pathological material, the number of metastases increases up to 25 of them. It means 5 times more than we expected according to the preoperative examination. Because, despite Anders, the accuracy of preoperative imaging in this setting is very low, ranging from 20% up to 50% of cases. So probably we would say that it's an unrealistic field because it has been already published the only study looking at the possible use or usefulness of a chemotherapy in the adjuvant setting after resection for liver metastases. And the only trial done at Beaujon Hospital did not show any advantage whenever a regimen with strepto and 5-FU was used with 4 cycles for 6 months, comparing the group of observation patient. However, probably in this trial there is more than the one thing wrong, because it's not a randomized study, is biased for the fact that the patient to be sent to chemotherapy were selected according to some criteria of aggressiveness, and there is no clear value described in the study as regards proliferative index or grading, as we now call the aggressiveness of the disease, and also chemo was performed or was administered in 65% of the patients with a KI 67 less than 5%. And we know that for a cytotoxic drug is a very weak target. Despite this, I imagine that we can use an hypothesis of work with, again, a multicenter randomized clinical trial using as a control arm an observation group of patients resected radically for liver metastasis of neuroendocrine tumor, using as active arm somatostatin analogs, everolimus, PPRT, or SIRT. But again, we do not really know which could be the target, probably disease-free survival at 2 or 3 years, and the treatment time probably must be chosen according to the toxicity of different drugs in the active arm of the study. And the same is probably after radical surgery, whichever the site, for G2 tumor of pancreatic or midgut origin. The drug under study, under possible experimental study, are almost the same, and again, the choice of the target and the treatment time would be chosen or should be chosen according to the toxicity and disease-free survival in the control group according to the data that we already have in our retrospective series of patients. So try to summarize the issue of adjuvant therapy. I have to admit, despite I am a surgeon, that a rationale exists because exists the population at risk, and we almost know who are these patients who will eventually recur because of not radical surgery. The possible aim or the possible target should be disease-free survival, since despite recurrence, these patients live longer than we expected for other types of cancer after recurrence. Possible drug must be chosen according to the G code, such as probably cytotoxic drug for high grade of the disease and somatostatin analog for low grade of the disease, being everolimus in the middle for G2 tumor. And the clinical field are for sure G3 radical resected carcinoma, liver transplantation for neuroendocrine metastasis, as well as liver surgery for neuroendocrine metastasis, and probably due to quite high figure of recurrence rate, G2 tumor radically resected. But in my talk, I should cover also neoadjuvant therapy. And I would like just to remind for those who are not oncologists in the audience that neoadjuvant therapy aim is to reduce the risk of recurrence in patients judged as resectable. It's quite strange to think this in neuroendocrine setting, but on the other hand, we may imagine to extend the role of the possible role of neoadjuvant therapy also in order to try to make resectable patients with borderline or unresectable disease. But here, in order to try to make the story short, again, we have some drugs that are able to be cytotoxic and some other which might be just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, the cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just cytos might study, just might study, just cytostati, just cytos might, just cytos might study, just my style, just my style, just cytos my style, just my style, just cytos my style, just my style, just my style, just cytos my style, just my style, just cytos my style, just my style, just my style, just cytos my style, just my style, just cytos my style, just my style, just my style, just cytos my style, just my style, just cytos my style, just my style, just my style, just cytos my style, just my style, just cytos my style, just my style, just my style, just cytos my style, just